Okay.
So mainly he had dyspnea initially to begin with, the dyspnea, which can be angina equivalent symptom because it was NYHA class 2 only. Then later on he developed typical angina. He also had palpitation, which can be because of ischemic ischemia leading to arrhythmias. And he also had syncope, which is basically in ostial LAD, left main disease, or even RCA involvement. And he underwent coronary angiography. That's why we are thinking about coronary artery disease. Next slide. Valvular heart disease. Dr. Rajesh. So why we are thinking valvular heart disease? As he said, aortic stenosis.
Sir, he has history of pre-syncope, sir.
Pre-syncope, okay. So how in valvular heart disease pre-syncope occurs?
Sir, because the peripheral circulation is compromised because of stenosis.
Peripheral circulation. So basically, they are having, in case of obstructive lesion at the LVOT, they can have a reduced cardiac output. Yes. Okay, and sometimes because of valvular heart disease, they might have arrhythmias. So, and they also have deranged barometric reflexes that can cause. So, next, Captain Kiran. Why we are thinking of cardiomyopathy in this case?
As the patient has pre-syncope, that is common in cardiomyopathy. So.
Pre-syncope occur in which type of cardiomyopathies?
So it occurs in hypertrophic.
Hypertrophic. So how this happens in hypertrophic mechanism?
So, because of dynamic obstruction, sir.
Yeah, if it is obstructive, then it can lead to, again, because of obstruction, there can be reduced cardiac output. And other cause? Arrhythmias. They can have even HCM, it is known, they can have ventricular tachycardias, they can have atrial fibrillation, because in HCM, atrial kick is very important for LV filling. In case if they have atrial fibrillation, they can decompensate very early and they can have syncope also. Okay, next slide. So we can think of dilated cardiomyopathy, but in this case, dilated cardiomyopathy generally angina is very rare, unless it is ischemic. Then acyanotic congenital heart disease. The fourth thing we thought about in this case is Dr. Ritesh, Dr. Anil. So why we thought of congenital heart disease? Dyspnea. When dyspnea occurs in congenital heart disease? In this age, so after 40 years. If initially he was okay, then why after 40 years of age?
ASD, AC migration.
Captain Kishore? Major Gaurav?
Acyanotic heart disease, like it affects our.
So why dyspnea occur in those?
Because is it mixing of blood? Where
just display the slide. So basically, left to right shunts, when there is increased pulmonary blood flow because of shunt, then lungs become better. There is increased flow. So that can cause dyspnea. And secondly, when they started having PAH, during that time, dyspnea will aggravate and they can also have angina. So we can think about any congenital heart disease also in this case. Yeah.
Upon general examination, his height was 167 centimeter, weight was 64 kgs, with a BMI of 23.8 kilogram per square meter, upper segment, lower segment ratio 0.91, and arm span to height ratio 0.97. His pulse was 62 per minute, regular, rapid, jerky, bifid in character, normal vessel wall, no radioradial or radiofemoral delay, with no apicoradial delay.
So, Major Ayush, what are types of double peaking pulse? You know about any double beating pulse?
Dichrotic pulses, Bispherian.
Yeah, Bispherian. What is this pulse? In which condition we see it?
AR.
AR. Basically, yes, AR. Okay. Any other double beating pulse?
or aortic stenosis.
Aortic stenosis may pulses forward set TARDAS. Okay. Slow rising, late peaking. Okay. So basically, these peaking pulses are of three types. Viscerian pulse, in which we see two peaks during systole only, and other is spike and dome. Again, in systole, one is prominent, then other wave is dome shape. It is slightly slower. Again, S2 differentiate. They occur before S2 in systole only. Then one is dichrotic pulse, in which the second peak is after S2. Basically, it is in diastole. So Viscerian, as we discussed, the AS, AR, then spike and dome is seen basically in HOCM. And dichrotic pulse, Tiwari, Dr. Tiwari, where we see dichrotic pulse.
Like cardiac failure, sir.
Yeah, heart failure. Any other cause? Basically, fever, sepsis, when there is peripheral vasodilation and increased cardiac. Next slide, please.
His BP was 128 by 72 millimeters of mercury, right arm supine, with no significant difference in upper limb and lower limb pressures, SpO2 of 99% at room air, respiratory rate of 18 per minute, temperature 98 degree Fahrenheit, JVP of 6 centimeter above the sternal angle with prominent A wave with negative abdominojugular reflex. There was no pallor, icterus cyanosis, clubbing, or pedal edema, no neck swelling, no marfanoid features, no xanthoma, xanthelisma, arcus senilis, no acanthoma nigricans, skin tag, pigmented patches, no evidence of any syndromic facies. His fundus examination revealed no evidence of hypertensive retinopathy, no evidence of infective endocarditis or fresh rheumatic activity. Hill's sign was negative. Upon systemic examination, cardiovascular system, inspection and palpation, apical impulse was visible in fifth left intercostal space just medial to mid-clavicular line with no scars, dilated veins or sinuses. Apical impulse was palpable in left fifth intercostal space, medial to mid-clavicular line, heaving triple ripple type of apex with palpable S4. Thrill was present medial to apex.
Major Suma, what is triple ripple apex? Okay. So basically, triple ripple is it usually seen in cases of HOCM. So there are three beats we feel during at apex. Three impulses. First is because of normal systole ejection phase. When systole occurs, ejection phase. And second is when there is dynamic obstruction after that, which we get at apex. Second phase is that. And third is when we feel S4. So this becomes a triple ripple type of apical impulse. And what are the characteristics of normal apical impulse? How will we define normal apical pulse?
The lowermost and outermost cardiac
Lowermost, outermost part of
cardiac impulse.
maximum cardiac thrust or cardiac activity. Okay. So, what is the size? What is the duration? Major Arvind?
So a normal apical impulse is less than 3 centimeter, lowermost and outermost part
Less
of
than 3 centimeter means?
it must be felt in less than 3 centimeter.
So basically, it is around 2 centimeter, 1 to 2 centimeter, and located generally in the fifth intercostal space, one intercostal space only, and it has just gentle tape. It comes and goes, and duration is it lasts in 2/3 of systole. It don't extend in the last third of systole. And what are the factors which affect apical impulse? As he displayed in physiological and pathological. So when we get abnormal apical impulse, what are types of abnormal apical impulse? Next slide, please. So any abnormal apical impulse, as we had in this case, triple ripple. Captain Suresh. Major Amit.
Physiological causes after exercises. Pathological can be in sepsis.
No, what type of pulse? What type of? One is we say this is apical impulse is normal, gentle tap. And what are other kinds of pulse? Just display this slide, please. So one is hyperdynamic pulse, which is seen in volume overload condition like AR, MR, or high cardiac output state, anemia, thyrotoxicosis. Says you feel hyperdynamic pulse and sustained apical impulse, which is seen when there is pressure overload, when there is some obstruction increased afterload. So pulse is sustained. So you feel some sustained activity at the apical impulse. Then tapping impulse, as we said, it has a normal also. Then it is seen in MS. It just comes and goes, touches your finger and goes. Then it diffuse or laterally displaced in seen in dilated cardiomyopathy, hypertrophic. It becomes sustained again. Then bifid, double peaking HOCM. If you feel S4 also at apex, then it becomes triple ripple. Then apical impulse, sometimes you may not be able to feel in obese COPD patient, or there is pericardial or pleural effusion. Next slide, please. So, Major Dinesh, what is S4? As in our case, we had just heard S4 and palpable S4 was there. So, what is S4? Even we discussed also, just right now. Yes, display this. So, there are two sounds, S3 and S4, which are low pitched sound. Okay, you hear with the bell of stethoscope, low pitched sound. And they are usually, they can be right sided or left side. So S3 is because of rapid ventricle filling. As ventricle is filled because of any increased flow or when there is rapid filling. So you hear S3. And S4 is basically, it is seen when atria contracts. It is the last phase of diastole filling. So S4 you hear when atria contracts and there are some resistance at the ventricle level. So when we see this resistance, in which conditions we see? It is seen in like hypertension, old age, then AS, then HOCM, when there is ventricle hypertrophy. It can be on the right side or it can be on left side. In left side, we discussed hypertension, aortic stenosis, HOCM, even in myocardial infarction. When patient have just present with myocardial infarction, during that time, ventricle becomes non-compliant. And then right side you can see in pulmonary hypertension, pulmonary stenosis, because then RV becomes non-compliant, or in when there is right ventricle hypertrophy. Next slide, please.
On auscultation, S1 was heard. Aortic and pulmonary component of second heart sound were normal with a normal split. LVS4 is audible best at apex in left lateral position. No S3, clicks, opening snap heard, no carotid bruit appreciated. Grade 4/6 harsh ejection systolic murmur, crescendo decrescendo type with at left lower parasternal area, not radiating to carotids or any other area, was heard. A grade 3/6 high pitch pansystolic murmur heard at apex, best in expiration with the diaphragm of the steth.
So any ST resident, just interpret the murmur. Rajesh, interpret the murmur.
So the first murmur, that the harsh ejection systolic murmur, is likely it's likely the HOCM murmur, sir. It's the murmur which is because of the obstruction, and the second is the
How
pansystolic
you
murmur.
can say HCM?
Sir, HCM or aortic stenosis. Sir.
Aortic stenosis.
Aortic
Okay.
stenosis.
Okay.
Some kind of obstructive kind of murmur, and second is the pansystolic murmur, which is heard at the apex. So it's an MR murmur, sir. Best heard in expression. So it's likely an MR murmur. So in this case, it can be because of the SAM.
So we had ejection systolic murmur and pansystolic murmur. So we can think about any obstruction at the aortic level, aortic stenosis, or LVOT obstruction, HOCM, or we can see this pansystolic murmur, in which condition